what is so-called wrong with US healthcare is intentionally wrong and
Well,
self-inflicted.
yeah, this is particularly related to a monopoly, and so you really hard to practice medicine and get paid if you are not board certified. So sort of a de facto regulatory body, and it's a private organization, and it brings in a lot of money. And what happened is that the requirements for certification for remaining certified became onerous. Came with a price tag. You paid $250 to maybe $500 a year, which doctors can afford, but it results in a lot of money to this private company. And that you can't help but believe that that's the motivation by all these new requirements that were dumped on us a decade ago. So they were bringing revenue of about $55 million a year 10 years ago. Now it's 105, and it grows every year. And 62% of that is now from this maintenance, where we have to do ongoing testing and fill out forms, get on your computer and click here and there and, spend whatever, 20, 30 hours a year and give them a check every year. They create test questions for us that are outdated usually, and you got to figure out what the right answer is, but it's not really how you would practice medicine.
Welcome to Analyzing Healthcare podcast, brought to you by Scale Community. Scale Community is a global healthcare-focused member network where healthcare leaders come to connect, learn, share ideas, and shape what's next in our evolving healthcare landscape. To take advantage of all that Scale Community has to offer, from expansive content to virtual and in-person events, to interactive peer networking opportunities, and more, check out Scale Community at www.scale-community.com. Membership options range from free to paid, so if you enjoy today's discussion, please take a moment to sign up for your preferred membership level.
All right. I want to welcome everyone to Scale Community's latest Analyzing Healthcare podcast. I'm joined by Dr. Paul Teirstein. Can I call you Paul?
You can call me.
Love it. Thank you, Paul. Pleasure to host you today, and I'm really excited for our conversation. We're going to cover some really important topics. We're going to get stuck in here. So, Paul, a little bit of your background. You're with Scripps Health, which is a health system in San Diego, and you're part of the cardiology department. You want to give us just a little bit of background and maybe include in that how we ended up together through me reading one of your opinions on the Wall Street Journal.
So I'm just a cardiologist. I have been in practice for a long time now, about 40 years, and I run the cardiology division at Scripps Clinic in San Diego. I do a lot of heart procedures, a lot of coronary stents, and now we're putting in heart valves without open surgery now. So I work in a place we call the catheterization laboratory, where we do minimally invasive surgeries. And that's most of my day, is doing that and training young doctors in a fellowship program and doing clinical research. But I see a lot of patients and have a lot of patient care interactions. So I know the U.S. health system very well. About 10 years ago now, a little over 10 years ago, got upset, as many doctors do, with various things throughout our day. I got upset with a company called the American Board of Internal Medicine, which led me to start a competing certification board, which led me to write an op-ed piece for the Wall Street Journal, which is an answer to your question of how we met. I think you read the Wall Street Journal piece, and that's why you're interested in talking to me. And I'm not really an activist, but I got kind of in an activist role 10 years ago with this project.
You know, it was an article that really hit a note with me, because I've had a sneaky suspicion while I've been covering US healthcare that a lot of what is so-called wrong with US healthcare is intentionally wrong and self-inflicted.
Yeah, this is particularly related to a monopoly. And, I would say that if you were to ask your doctor, or if you have a friend who's a physician, especially if they're in internal medicine, a non-surgical specialty, they're not for profit, but not a governmental board. It's a private board that certifies doctors, probably the most despised organization in medicine by the physicians. Physicians hate it.
Is this the American Board of Internal Medicine, or is that?
The American Board of Internal Medicine is the biggest of the 24
24 of them.
And it is, they certify internal medicine. So that'll be your internists, your general practice doctors, your cardiologists, your endocrinologists. They certify over 200,000 doctors every year. And so you've all heard the phrase board certified doctors. It sounds kind of good, right? And it used to be 100 years ago, it was a distinction that made you special. You were going to get some special training and maybe take an exam, and then you would be board certified. So it was a distinguishing mark. But what happened is over the course of time, it became pretty much a requirement to practice medicine. So 95% of all doctors are board certified now. And it became a requirement, not by the government. So Medicare, CMS, does not require a doctor to be board certified to get paid. But most insurance companies require a particular board certification. It's one board. It's the American board that they require. And most hospitals, therefore, require it. So you really hard to practice medicine and get paid if you are not board certified. So sort of a de facto, not sort of, but a de facto regulatory body. And it's a private organization. And it brings in a lot of money. And most doctors...
You mentioned in your article $105 million in revenues.
For a physician, it's just insane for us doctors to hear this. So when I took on this project 10 years ago, what happened is that the requirements for certification, for remaining certified, right, for maintaining certification, became onerous and just overwhelming and infuriating. And of course, it also came with a price tag. You paid $250 to maybe $500 a year, which doctors can afford, but it results in a lot of money to this private company. And that you can't help but believe that that's the motivation by all these new requirements that were dumped on us a decade ago. So they were bringing revenue of about $55 million a year 10 years ago. Now it's 105. It grows every year. And 62% of that is now from this maintenance, these new requirements that were just put into place a decade or two ago, where we have to do ongoing testing and fill out forms, get on your computer and click here and there and, spend whatever, 20, 30 hours a year and give them a check every year. And so they have an organization that's got 250 employees. They create test questions for us that we don't like, that are outdated usually, and you got to figure out what the right answer is, but it's not really how you would practice medicine. Their leader if you look at their 990, their tax form, for 2023, their leader made, he was a doctor, no longer practicing, but a doctor making $1.3 million to run this company, which just seems absurd.
You do the maths. If you did 200,000 times $500, you get to 100 million. So that gets you there real fast.
Well, there's a lot of people, yeah. I think, what do? They do the same thing my organization does. I have a competing organization, but they also supply test questions.
Let's ask the obvious question. So if maintaining board certification is a bit of a racket, I'll be controversial intentionally. Why create another one? How does the organization and your National Board of Physicians?
Yeah, yes. So they're the American Board of Medicines. We're the National Board of Physicians and Surgeons. And so that question was asked of me when I started it, like, oh, you're just going to be as bad as them. And so the answer is, well, we're not. And our mission is to be reasonable and to have requirements for ongoing maintaining your certification that make sense and that are not about gouging physicians. So, for example, I don't get paid anything. None of the physicians get paid. We have a staff who get paid reasonably. We don't have their director of research who writes papers justifying their existence, which do not justify their existence. She gets paid $500,000 a year. And there's all kinds of perks they have. Until I showed up on the scene 10 years ago, their significant others who could go on these trips with them, and they would get reimbursed for their spouse's travel. I mean, things that we would never do in medicine, that just would be completely unethical and are wrong. So we don't do any of that. And what I told doctors who were questioning me about this when I started, I said, listen, your job is going to be to hold this organization accountable. I'll do it as long as I can, but at some point it'll get passed on and then it's up to you. Just like I want to hold the American board accountable by starting this organization. The doctors are going to have to decide whether they think we're doing the right thing. We've now got 15,000 doctors certified. We're approved in 250 hospitals, and we're growing. But it's hard because the American board has sort of injected itself into the whole bureaucracy and the fabric of medicine. And so to get our board approved is challenging, but we're making progress.
It's, I would imagine, challenging to the extent that payers are limiting who they will and they won't recognize as board approved. So if they're insisting on American board versus your group, that makes things very challenging for physicians.
Well, they also have a lot of money. So wherever we go, they have some lobbyists to try to prevent it. I mean, it's not the way us doctors think about how medical organizations should behave.
Yeah.
They're monopolistic. They're a complete monopoly. And what we're trying to do is break that monopoly. And we really could use the federal government to help us with that.
We're trying to get rid of monopolies wherever we see them in healthcare, and they're all over the place. Hospital monopolies, payer monopolies, board monopolies, government monopolies, and occasionally private equity-backed MSO monopolies, although not in such frequent numbers. But we do see monopolies in healthcare, and we do not like them. I have to say, they normally come with all the things that you're taught to fear from monopolies, which is bad service and inflated pricing. So I wonder have you studied the history of the American boards, whether they started off far more altruistic and they lost their mission and their focus along the way? Or was this always an organization that was not necessarily focused on making life easy for doctors?
No, you hit it on the nose. 100 years ago when this started, it was not quite 100 years ago.
I hear you, great.
So it started about 90 years ago, and I think it was very well intended. I think medicine was very different then. There were charlatans, and there were people advertising that they can do things that they weren't trained to do. So the idea was to put some training into it. And I should also explain that myself and most of my fellow doctors are not against initial certification by the American board. The way you earn your certification is you do a training program. And that's overseen by a whole other not-for-profit group. That's a private group called the ACGME, the American College of Graduate Medical Education. And that's the group that makes sure that we get trained well. They come and audit our training programs, and there's all kinds of rules about that. And they do generally a very good job. And then the other private organization, the American board, they provide a test at the end of that training. And the test has lots of problems, but it's like a final exam. It's like the bar exam, and you study up for that, and you take the test, and you have to kind of know everything when you finish your training. But then, 10 years outside of your training, when you subspecialize in certain areas, to have to go, for example, if I have to read about pediatric cardiology, that's just a waste of my time. It's vaguely interesting, but then I'm going to forget about it a minute later because I don't use it. So that therein kind of lies the problem. We're okay with the initial certification, and in fact, the national board that I started requires initial certification by the American board that I'm against. We provide a different kind of maintenance of certification that isn't corrupt, frankly, and isn't just trying to make money off doctors.
Healthcare leaders, if your revenue cycle management is underwhelming you, it's time to rethink your current suite of solutions. Scale Healthcare's AI-powered RCM solutions are purpose-built to protect and accelerate revenue across the entire life cycle. Denial Shield proactively prevents denials before claims ever go out, using agentic AI to automate root cause detection and resolution. Front Desk Shield streamlines preclinical and front-end workflows, eligibility, authorization, and intake, reducing friction before revenue is even created. And Revenue Shield maximizes charge capture and revenue integrity, ensuring nothing slips through the cracks. Together, the Shield suite helps organizations reduce operating costs, capture missed revenue, accelerate cash flow, and increase productivity, without ripping and replacing existing systems. If you're ready for immediate ROI and measurable impact, visit scalehealthcare.com and see how the Shield suite is redefining AI-powered RCM. Well, we've got we've got a few things going on here in this marketplace that lead us to where we are today. Countervailing forces. We've got the need to create a central standard. You see that in rating agencies as well. Everyone feels more comfortable going to bed at night knowing that Moody's is a rating agency because everyone knows Moody's. Everybody knows S&P. And if we had 1,000 different rating agency brand names, everyone would feel less comfortable going to sleep at night. There's a lots of things in life that we have 1,000 of. We have thousands of restaurants, but we don't want thousands of rating agencies. So everyone feels good going to sleep at night knowing that the American Board of certification exists for physicians across the US, across America. However, there's a price you pay for that. And on occasion, I agree with you, Paul, sometimes the price is too steep. Right. And a big difference between 2, 3, 4 competitors and a market that's open to new ideas versus no competitors, pure monopoly, no new ideas. Let's keep testing the way we've always been testing, even though it might be stale. Let's make sure the tests don't keep up with evolution in medicine. Let's still use paper. Let's charge a higher price so that we can inflate our wages. Right, as opposed to lowering the price. Why isn't the price lowered every year as opposed to increased? So all these penalties that you incur as physicians when it's only one option, only one supplier in the marketplace. So I think I understand how we get here because everybody wants a small number of brands to represent safety in physicians. But you end up with a far inferior product if what you're telling us, Paul, is these tests don't really amount to much. Right? They're not really telling us. Board certified doesn't really say too much.
Well, this is important. You're raising a good question: is how do you maintain standards? To give you an example of how silly the test questions have become, you mentioned the word. Why don't we start using paper? So for cardiology to maintain certification with the American Board, I have to jump through a bunch of hoops. And one thing I would have to do is take 30 test questions that come to my computer every quarter. That's 120 questions a year. And when I started the national board, when I started some competition, they were having us go to a testing center every couple of years, which was absurd. But I've got them to back off now. And not just me, I should say, but we're part of an anti-American board program that has got them to change it. So now you get 30 test questions every 3 months. Do you know how easy it is for ChatGPT to answer these questions correctly? I mean, all you do is aim your camera at your computer screen and take a picture and then say, answer this question. And it gives you a wonderful analysis and always gets the question right. So this is basically make work that they're giving us. This is an education. Most doctors like education. We like going to continuing medical education seminars. We like reading journals, but these is really onerous testing, just doing task after task, like being on a mouse wheel, is what we get so upset about. And, there's a physician shortage now. I know if you tried to get a doctor's appointment lately, it's harder and harder. And these kinds of requirements make doctors retire. We just say enough.
So 120 questions per year on top of whatever HR questions you're getting if you're part of an institution, on top of filing your taxes, on top of your EMR, on top of all the other.
It's a lot of make work. Yeah, you were doing a lot of data entry.
It's not like it's the only organization asking you questions per year. It's one of several.
These are particularly annoying. And then if I did the math on this, the American Board of Internal Medicine, they have actually 20 specialties that they write questions for. So if they wrote new questions every year, which they don't because they repeat them, it works out to 2,400 questions. And I've divided that into their revenue. It's $25,000 a question. It's kind of ridiculous.
So 2 issues here. I want to come back to the second issue in a second because that's a major issue for me. But I think the first issue is just as worrisome, right? If the whole program, board certified, is illusory and manufactured to create a false sense of confidence and lacking in any real substance because any physician can pass any board eligibility test anytime they want. I mean, I wonder what the failure rate is. Who are we kidding? I mean, that is a major issue in US medicine. It's supposed to be a safety mechanism. It doesn't sound like it's playing that role. It sounds like it's just a tax, and it's just there for us to pat each other on the shoulder and say, everything's good, let's go to sleep sweetly at night. But it doesn't sound like there's real bite and substance to it. And by the way, there are many other ways to evaluate a physician's performance, which lots of groups are interested in. Adverse events, infection rates, key KPIs for the given specialty, right? There's many different bodies that are interested in physician performance. It doesn't, maybe the board certification is an organization whose time has come and gone.
Well, just to be clear, the initial certification we do think has merit, and you don't see an uprising against that. But
we're not talking about the initial.
Competence is the question. Most of us believe that accredited continuing medical education, so there's another private organization that accredits
CMEs. That's a little different.
And that is really how we do it. In the real world, that's how you stay current. You go to conferences.
You earn your credits.
There's a lot of ways you can get good CMEs, and it's very valuable. And that's how you stay current. This idea of having to work with the American board to maintain your certification is a very new idea. And it seems tied mostly with not so much patting ourselves on the back, but mostly giving them money. It's like a toll booth for doctors. It's $250 to $500, depending on how many certifications you have, or it could even be more than that. But doctors can afford that. But it's the amount of, you can see the carrot here with why they're doing this is so they can make their $100 million a year.
Tax and waste in a system that can't afford tax and waste, not waste of time, not frustration, unnecessary frustration for physicians that are frustrated already for a whole host of reasons in a marketplace that's short on physician supply. Let's go to the second issue, which you highlighted, which is another reason for physicians to retire. I want to walk you through some of the other constraints on supply that we're facing, many of which I think are actually intentional and don't have to be this way. And I'd love to hear your thoughts on each of them. So I have quite a number here, but I think they're all connected. So the first one is medical schools. How many are out there? How many graduates every year? Are these medical schools acting as their own bottleneck on supply? Compare medical schools to business schools, law schools, other post-grad schools of any type. Is the medical school part of the problem when it comes to supply? What are your thoughts?
I have never viewed it that way, just because I've been involved with medical schools. I went to medical school. I've taught. It seems like the process is, it's complicated and it's lengthy. I mean, it is lengthy.
To pinpoint the culprits, because at the end of the day, this supply chain produces too few of everything, right? Too few orthopedic surgeons graduating every year, too few neurosurgeons, too few everything. Right? Every single specialty claims to have material.
So first, I'm an expert on how to solve this problem, but it seems to me that one of the other ways out of this is to increase the size of the training programs after medical school.
Right. So that's where I'm going next. I'm going to residencies. Right?
Yeah, the residencies.
And by the way, not lost on me that many of the medical schools and the residencies are provided by the same source, which is academic hospitals, right? Academic health centers responsible for both. And hospitals have a tight control on supply of care in many markets at the end of this supply chain. So is it underfunding, or is it a controlled marketplace that wants a very controlled amount of dermatologists to graduate every single year? And what's interesting is, why doesn't the market, I mean, the US market is supposedly very mobile. And what you produce in California, excess dermatologists, you could conceptually ship over to Texas, shortage in dermatologists. And yet, every year, as long as I've been in healthcare, and I haven't been as long as you have, I've only been in healthcare 15 years, but every year that I've been in healthcare, there's been a chronic shortage of clinicians from every specialty across the board. That doesn't seem accidental to me. It seems self-serving. For those who are in the profession, you're desired.
Well,
almost like an exclusive club.
The way residencies are funded is from the government. It's through Medicare funding. And in fact, there is something in Congress, a bipartisan act this year, it's called the Physician Shortage Act. And the idea is to increase funding so we can have more residents and more trainees, which I don't think anyone is against. I mean, it's bipartisan. The doctors would favor it. I tell you, from a physician's perspective, someone who works hard, seeing patients, the last thing I would ever worry about is not having enough patients if we had too many doctors. You really feel a lot of pressure right now to get patients in and to work late. I can't imagine what kind of doctor would try to limit more physicians going into our world. I think it's
You see
funding.
limitations on medical supply in many elements, right? And you see medical associations put a kibosh on supply in many ways, restricting international clinical solutions, right? We don't want doctors overseas taking care of patients over here, no matter what they go through in terms of accreditation, in terms of audit quality control. It's just a hard no. It's illegal in the US. We don't want telemedicine to run rampant across the US, right? You see a lot of associations, medical associations, that advocate for positions that de facto result in less supply, not more supply. And there's often a very valid explanation. We're erring on the side of conservative, we're erring on the side of quality. And by the way, these are the same explanations they use to justify the American board. So it's not just the American board that benefits from this. It's a lot of groups that benefit from taking a very conservative approach to supply. And I'm sure that AI is going to go through the same ringer, again, partially for valid reasons and partially because it ends up with less supply, and less supply equals higher wages. So it's just interesting to me, the number of residencies in this country, 44 a year. That's it. The number of applicants exceeds the number of residencies every single year. Every year. These are problems that you think could be easily fixed. And yeah, Medicare has an important role to play in residencies, but it's not a singular role, right? It acts in partnerships with health systems that provide these residencies, right? It's a support.
I'm with you 100%. I think that there should be more funding for residencies and for the training programs, and I'd like to see the funding tied to organizations, hospitals not requiring these onerous maintenance certification requirements as well. So there's a way to get that political agenda in, along with more funding. I think the answer is more funding for residencies. I mean, we would expand our training program here at Scripps if we had more funding to do so. It's just a matter. We use philanthropy, and we have some government slots, but they limited those. They cut those off back in the early 90s. And so maybe now because everyone's feeling this position shortage so acutely, maybe now we'll get some more funding.
I mean, I haven't done the research. I'd love to do it. It sounds like a fun project. Which institutions across the country have seen tremendous growth in residencies available, and why? You have to assume that there are some academic institutions that are driving a large, ever-growing number of residents through their doors, and they're benefiting greatly as a result, right? They're keeping a lot of those physicians. They're building a network of outpatient facilities. They're just loving the experience. It can't be like every one of these institutions is going through the same experience, right? So I would love to examine that. I haven't done the research, but what is going on?
My instinct is that it's not as nefarious as you make it sound. I think it just comes down to if we had, I tried to increase the size of my training program here. I run a training program, actually just 2 training programs in my division, and we're always trying to increase the size. And it always comes down to, well, can you get some grateful patients maybe to donate some money, because they have to get paid, and they don't get paid much. Residents get paid. They work pretty hard, and they get paid under $100,000 a year. When you think of your hourly wage, it's pretty low for a resident.
I think I would throw that into the list for reasons why there's a shortage of supply as well, right? The actual endurance aspect, the hardship of going through the entire training program, plus the costs, plus the debt. I mean, there's a long list of reasons why we have a shortage of supply. And I haven't done the maths on which of them is more impactful than others. I just find it really interesting that this list exists. And you're highlighting one of the key contributors, the board aspect, and they all are interconnected. They're part of this general constraint on supply. I would throw in the associations. I think they belong in this conversation. Are they really promoting more supply of clinicians, and what are they doing about it? Or is it too skewed towards whether it's intentional, self-serving, nefarious? I didn't use the word nefarious, but let's use that too. Or whether it's unintentional, just too conservative, or I'm just too distracted on other issues to focus on this problem of supply and really opening it up. How would these associations feel about foreign doctors is a very big tell for me. Because if the answer is absolutely no, there will not be a single foreign clinician performing any care on any US patient ever, that is a sign to me that something is not quite right in the system, that we've lost objectivity and that we're prioritizing too much things that we shouldn't be honest with you.
Well, we have a lot of foreign physicians who were trained, who went to medical school, and
who are credentialed over here.
Without them, we wouldn't be able to survive.
Right, but I'm not talking about importing doctors. I'm talking about telemedicine and virtual care being provided by foreign-based clinicians that are fully accredited.
So that's interesting. That's state regulated. So that's the problem with crossing the state lines, that the state likes to have its own requirements.
And Medicare, right? Medicare doesn't approve it. And then our associations don't approve it either. So all these groups, all these constituents, they all speak to each other, right? CMS speaks to the American Medical Association. They all get feedback and input from each other. And it's rare that, the medical associations are pulling in a completely different direction. We have the healthcare system that we have designed. It didn't just fall on us. This is what we designed, and we've designed a system with an acute shortage of physicians. You mentioned in your opinion that 80,000+ physicians shortage forecasted for several years' time.
I think it's already, I don't know what it is right now, but it's pretty high. I mean, I've never seen so many of my patients and my friends, family trying to get in to see a doctor it's been 4 months just usually for a consult. And we have there's a lot of foreign medical graduates applying for residencies in the United States. And I think it's just a matter of funding, because you can find a lot of good people, obviously. And we have a lot of wonderful physicians that are practicing in this country that did some training here. You have to do something here so we can evaluate you, I would think. Has to be
funding plus incentives, right? There's plenty of money in US healthcare. We're reminded every day. There's plenty of money in US healthcare. So it's not just funding, it's funding plus incentives, which direct that funding to different initiatives. I think to reinforce your point, continuing education, the CMEs, hospital credentialing and privileges, the role that the payer community plays, auditing physician performance, the role the government plays, Medicaid lists, auditing physician performance. There's plenty of oversight of physicians. And I think that you raise a really good point about this board requirement and this singular entity that is out there forcing its framework, its view of what being board eligible is on everyone. I think you've highlighted a key flaw, but hopefully you understand where I'm coming from in trying to frame a broader problem than that. I don't know if we had 10 different options on board certification and 8 of them were very rational, right? Intelligent. They asked the right questions, they priced the right price. Would we remove the physicians shortage issue from American healthcare? My guess would be no.
I think it would be a step in the right direction, for sure.
A step in the right direction.
But I think the bigger question you're raising is, how do we break down barriers across state lines and across country lines to get more access to physicians?
Do we have a residency growth rate that is in keeping with, on par with our population growth rate? I'd like to see that mandated. Do we have an adoption of alternative sources of clinical care and supply that we're embracing? Right now, telemedicine is illegal in America, as per a 1998 act that is temporary and because of the government shutdown has not been renewed. That is a very damning.
Yeah, I haven't dug into the reasons of that. My instinct would be there to be too much concern about fraud, but because doing telemedicine that works. I can tell you from, during COVID, obviously suddenly it became illegal when it became necessary. So for a short period of time, it was quite.
Such a great point.
Yeah. So you could certainly take care of patients, and not only that, but patients like the idea of doing telemedicine. They don't have to take half a day off for work. It's much more convenient. And and sometimes you have to actually see them and examine them, but you can do a lot with telemedicine. But the question is, would you then have a situation? I think I always assumed, and I'm not an expert on this at all. I've always assumed that the reason we don't have just rampant telemedicine is that people are worried about fraud. Will there be real medicine going on, or will there be some kind of abusive medicine if people are just on the telephone or on the video? That's what I bet.
And this is one of the challenges, is that there's always fair criticism of medicine performed poorly by actors that don't get the job done right. That's always available to anyone who points in any direction, right? A hospital that engages in malpractice, a physician that engages in fraud, a system that there's always opportunities to criticize, but we have to dig deeper. And I think that what you've done so well, and I really have to applaud you, is shine a light on a part of healthcare that is monopolistic. And I think we can sort of end this discussion where we started it with. Anywhere that we're seeing singular supply, right? A medical association that speaks for everyone and always has. Anytime that we see singular supply, a payer that is singularly defining reimbursement rates, right? Without any alternative, singularly defining benefits without any alternative. We need to tread cautiously in those environments. I think that's sort of the lesson that I take from reading your article.
Well, monopolies are bad, and I think that our government can do something about this monopoly and really help us here. It's not going to solve all the problems, but it certainly make the doctors a lot happier to not be wasting their time.
Here's to that. Thank you, Paul. Thank you, Dr. Teirstein, for your time. I really appreciate your input today.
Thank you for joining us on Analyzing Healthcare. Stay informed and stay inspired. Don't forget to subscribe and visit scale-community.com to become a Scale Community member. Until next time, keep exploring the ideas that shape our healthcare systems.